We have our section now really introducing the appendicular skeleton. And the appendicular skeleton includes the larger percentage of our bones, larger number, and it includes the bones, the joints, the ligaments, of course, for our appendages, for our limbs. In particular, there are various bones that get the distinction of being a girdle, and these are truly just the bones that are used to attach our limbs onto the axial skeleton. So we'll see which bones truly connect our arms onto our torso, and we'll see the bones, of course, that connect our legs onto our torso as well. And in the lab, we'll see a select number of ligaments as well. So for example, we'll study the shoulder joint, the knee joint, and a number of ligaments. So moving forward, again, we can see now this view of the skeletal system as a whole. And again, the appendicular skeletal system has a larger number of bones. There's multiple bones just in our hands and feet. And we'll start with a comparison of each limb, comparing the upper limb to the lower limbs. So starting with the pectoral girdle, and there's that term, a girdle, the bones that connect to our appendages, in this case, the upper limb. And the bones that form the pectoral girdle are the scapula and the clavicle. So it's these two bones here that truly make our shoulder joint and this connection for our upper extremity. So we'll discuss its traits. So in this area of the pectoral girdle, we have now this connection between the sternum, specifically that manubrium of the sternum, and now the clavicle, so known as the sternoclavicular joint. And this is an important joint for our upper extremity because this is the only strong point of articulation between the pectoral girdle and our axial skeleton. Again, between the clavicle and the manubrium of the sternum. Whereas the rest of the pectoral girdle is actually extremely flexible, and we do want that flexibility of our shoulder. However, we're actually sacrificing strength in terms of flexibility. So for the scapula especially, the scapula is held in place by a number of muscles and their tendons, collectively known as a rotator cuff. And the scapula is extremely flexible. However, it's at the benefit of now sacrificing strength. So just continuing with that idea, we have what's called this glenohumeral joint. And this is now between the glenoid cavity on the scapula, and then of course, humeral, the humerus. And this is once again a very flexible yet weakly supported joint. And that always has to be the trade-off for any joint. If it's extremely strong, it's going to lack flexibility. Here we have the opposite case. So lacking in stability and strength, yet it's very flexible. And of course, that's a benefit for our arms as a general. And since it is so weakly supported, with trauma, from the posterior side especially, this joint can be easily and commonly dislocated, being knocked out of its natural position. So once we move into lab, we'll of course cover all of these bones of the pectoral girdle, the clavicle, the scapula, and then moving on down through the rest of the upper extremity. So we'll see the details and features of these various bones. So now in comparison, we have the pelvic girdle and now the lower extremities. So once again, with the concept, the pelvic girdle, now the attachment for the lower extremities, this is now composed of the coxal bones. So the paired coxal bones. Each coxal bone develops from three distinct embryonic bones: the pubis, the ischium, the ilium, and these three all fuse together and bond to make one single coxal bone. And the coxal bone itself now is the pelvic girdle. Those are equivalent terms, pelvic girdle and coxal bone. However, the term pelvis now is very different. The pelvis, notice here, spelled out, has multiple elements. So pelvis and coxal bones would not be equivalent terms. And we see here, well, a pelvis now has the paired coxal bones, the sacral vertebrae, coccygeal vertebrae, and the fibrocartilage of the symphysis pubis that's now bonding those two paired coxal bones together. So in this case, for the pelvic girdle, we're going to see the bonding between the coxal bone, that's the attachment for the lower extremity, and the coxal bone, of course, bonds on to the axial skeleton, and that occurs here at the sacrum. So what's known as the sacroiliac joint, we can start with the coxal bone. The superior portion of the coxal bone is formed by that ilium. And we see here where the ilium bonds on to the sacrum. That's that area of the sacroiliac joint. And in contrast now to our upper extremity, the upper extremity again for our shoulder joint, that was weak yet very flexible. Here we have the opposite orientation. The sacroiliac joint is the strongest joint in our body. So very strong joint, strongest one we have, which means, of course, a very decreased level and slight level of flexibility. And this is, of course, a benefit now. We have to support the weight of our torso coming right down to our pelvis, transferring that weight to our legs. So we need, of course, a very strong joint for the lower extremity. So now taking a look at different sexes, and of course, the role of hormones leading to these developmental differences between men and women. And what we're seeing here now is, of course, looking at the structure of an adult pelvic structure. And the reason why it's important to point out adult, many of these differences in sex are not seen until, of course, we have our secondary development in adulthood, and all these different changes occur. The skeletons of young children, boys and girls, are quite similar because they've yet to mature. So looking at this description here, compared to the male pelvis, the female pelvis has the traits that are described here on the screen. These are all descriptions of now the feminine pelvic structure. And we'll go ahead and discuss these and see the comparison. So what's meant here by a wider pelvic inlet and outlet? We'll take a look at the female pelvic structure, and it's now the width of the pelvic cavity, and that's a broader, wider canal in women than it is in men. And the pelvic inlet and outlet specifically now, there's a difference. The pelvic inlet we see here is the superior border of the pelvic cavity, and the pelvic outlet is the inferior border of the pelvic cavity. And both of those, of course, being wider and broader in women. There's now the position and curvature of the sacrum and the coccyx. And in the male pelvic structure, there's much more anterior curvature to the sacrum and coccyx. whereas in the feminine pelvis, there's less curvature, meaning that the sacrum and coccyx are pointing more inferiorly downwards, as opposed to anteriorly in men. So a lesser degree of that curvature. Looking at the position of the pubis, so these are the bones here lateral to the cartilage, and it makes sense. If the cavity is wider, the bones need to be wider to bridge that space. It also has a lower inferior position, where it's more narrow and higher in the male pelvic structure. There's now the bones. The plural term is ilia, or singular ilium. And in the male pelvis, we notice it's a more vertical position, whereas in women, it fans out further laterally. And then another trait that's really a very obvious one is looking at the angle between the two pubic bones. And it has the measurement here, you notice. So it's a more narrow angle in the masculine pelvis, and it's a broader, wider angle in women. And of course, all of these traits with a wider pelvic inlet and outlet, less curvature to the coccyx and sacrum, the broader position to the pubis, the more laterally positioned ilia, and the broader angle. This, of course, all allows for supporting the weight of a fetus, and then ultimately the delivery of a baby through the birth canal. So with that wider, larger space for the ease of delivery of a baby. So now related to this section, of course, the knee is a portion of the lower extremity, and we'll take a look at a common type of sports knee injury, and we'll discuss the ligaments involved, and we'll see these structures in the upcoming lab as well. So a common type of knee injury in sports, especially contact sports, you want to think of football, soccer. It's known as a terrible triad injury. The reason being there's 3 structures in the knee that could all be injured in this one instance. So really destabilizing the knee. So how this commonly occurs is when a person has their foot flat on the ground, as opposed to being up on their toes. And in this position here, with their foot flat on the ground, they now experience some type of trauma, a tackle, a hit to the lateral side of their knee joint. And the issue is now, with that lateral impact, it could cause the knee to bend out laterally, something that this hinge joint is not designed to do. And that lateral bending of the knee could now start to strain and possibly tear structures that are on the medial side. And that's exactly where these features are located, towards the center or even over all the way to the medial side of the knee joint. And we notice the names. It can be called medial collateral ligament or tibial collateral ligament, medial meniscus. And you commonly hear this one abbreviated all the time, the ACL. The anterior cruciate ligament. This is an especially common sports injury. But a terrible triad injury, all 3 of these can be torn. And here's an example. So again, we describe that lateral trauma, that force coming from the lateral side of the knee. And that could cause the knee to bend sideways, stretching and tearing possibly. You notice again, the terrible triad, including that medial collateral ligament, the fibrocartilage of the medial meniscus could be ruptured. And here in the center of the joint, that especially sensitive, prone to injury, ACL, anterior cruciate ligament.